Today we will be proceeding with the examination of the respiratory system. For this examination we will be needing the following instruments: a stethoscope, a ruler or measuring tape, and a pen light. And the marker will be needed also for making specific annotations. The peripheral signs of respiratory disease are the first things that are usually taken into consideration, and they will be done from both an anterior and posterior aspect of the chest. We'll first start by checking out the general appearances, in which we do a global assessment quickly, and then that would be usually followed by YPEEP, as would have been mentioned in previous sessions, as well as the vital signs. We will then proceed to the general appearance that are specific for respiratory disease, which include things such as cachexia, signs of respiratory distress, which look like pursed lip breathing, intercostal muscle retraction, contraction of the platysma and of the sternocleidomastoid muscles. And then we will proceed to specific areas where we start with the oral cavity. A pen light is usually utilized, and we check for signs of cyanosis, which is a bluish discoloration, and we check this in the mucous membranes, the lips, and the tongue. While we are doing this, we will also observe a halitosis, which is a foul smell observed in the oral cavity, and hoarseness of voice, which we can observe by asking the patient to speak to us.
Good morning.
We will then continue with the examination of the nose, in which we will check for the patency of the nostrils. We do this by asking the patient to occlude one nostril and breathe in, and then we do the same for the other. We will then quickly examine, again using the pen light, for septal deviation, septal perforation, and the color of the mucous membranes. We will then continue with the examination of the eye, in which case we will be observing for signs of anemia. This will of course be pallor of the palpebral conjunctiva. So we do this by looking into the palpebral conjunctiva and asking the patient to look up. And we do the same for the superior. We will also quickly be checking for signs of Horner syndrome, which in this case will be palpebral ptosis. We can check this by asking the patient to follow our hands downwards. We then continue in the region of the neck, in which case we'll just be observing for engorgement of the vein. So we ask the patient to make sure that the neck is completely exposed. And we check the neck for engorgement of the veins. We will also check quickly for lymph nodes, and in which case we will specifically palpate for the supraclavicular lymph nodes. Remember specifically that on the left side is indicative of respiratory cancer. We'll also check the trachea to make sure that it's midline. And then we will be observing the space between the SCM and the trachea, which should be equal on both sides. We then move on to the region of the hands, which we'll ask the patient to hold both hands out. And we'll be checking for clubbing. And then we do the Shamrock's test. We'll also be looking for any signs of pigmentation, which can be indicative of nicotine stains for chronic smokers. And then lastly, we will be asking the patient to hold his hands out and dorsiflex, in which case we will be checking for flapping tremors, also known as hysteresis. The last region that we do examine for peripheral signs of respiratory disease is the lower extremities, where we check for signs of edema. Edema is usually checked for in the legs, so ideally the patient is either in a lying position or the sitting position. Alright, you check for pedal edema, as demonstrated before, in the pretibial region, 2 to 3 seconds against the tibia. Also in the area of the medial malleolus, and also in the area of the dorsum of the feet, the same protocol. Good. This completes the examination of the peripheral signs of respiratory disease. We will now proceed with the focus examination, in which case the patient is ideally lying in a decubitus with some elevation and appropriately draped. Exposure of the anterior chest wall would be ideal, so we'll ask the patient's permission and do the appropriate exposure. First thing we do is that we examine for the surface markings, which should be easily identifiable. They will include the nipples, the manubriosternal junction, the suprasternal notch, the vertebral prominence, which you will see when we do the posterior part of the chest, and the clavicles. We will first start with the scale of inspection. Symmetry is the first thing that we look for, and we observe the chest to make sure that it is bilaterally symmetrical in size. We check for deformities or lesions. We check for the position of the ribs. Please recall that the ribs are normally positioned obliquely. We check for the intercostal muscles, and we observe the movement of these muscles. Please recall that intercostal muscle retraction is usually indicative of respiratory distress. We ask the patient to take a deep breath, and we watch for symmetrical movement of the anterior chest wall. And we observe also the abdominal movement. Remember, respiratory movement and abdominal versus thoracic. We then proceed with palpation. For the scale of palpation, the first thing that we palpate for is tenderness. So we will palpate the chest and observe for painful response by the patient making a sound or by a change of his facial expression, ideally a grimace. Once we've done this completely, we proceed to check for tactile fremetus. For this one, we ask the patient to say the word 99, and we feel the vibration on his chest walls with the balls of our hands or the ulnar border of the hand, comparing both sides. First in the apical region.
99.
And then at the same level on the other side.
99.
Then above the pectoral region.
99.
Same level on the other side.
99.
In between the pectoral region.
99.
And again the same level.
99.
Below the pectoral region.
99. 99.
And in the axillary region.
99. 99.
We then proceed with the chest excursion, and this is usually done as follows. First, place both hands lightly on the anterior chest, starting at a position above the pectoral region. The thumbs should be touching each other in the midline. Then, with a sweep of both thumbs laterally, a fold of skin is picked up between the thumbs. The patient is then asked to take a deep breath in and then out, and observation is made to see the movement of the thumbs and the pinch of skin. The separation of the thumbs and the flattening of the fold of the skin during the expiration is expected, and both thumbs should move the same distance away from the midline. The same is repeated at the level of the nipples. And the costal margin. Please beware that you should not press too harshly, or you will actually impede the expansion of the chest. Next, we will proceed with the measurement of the chest AP and lateral diameter. The AP diameter is the distance that is measured between the anterior and the posterior axillary lines. We do this by observing the position of the lateral lines, which should be in the same position of the anterior and lateral folds of the axillary region. We use the tape measure for this, and it should be used in the inch measurement. So the lateral diameter is the distance between both anterior lines. and the anterior posterior diameter is between the axillary line on the posterior end and the axillary line on the anterior end. We then compare these two measurements into a ratio. Normally the ratio is 1 to 2 or 5 to 7. What we will be looking for here is a ratio that approaches 1 to 1, which may be indicative of barrel chestedness, which can be because of certain chronic diseases, such as COPD, emphysema. This concludes the palpation. We will then proceed with percussion. To percuss the chest, you should start in the position above the clavicle, between the intercostal spaces to the 6th intercostal space in the mid-clavicular line. The art of percussion will be the same that was demonstrated earlier in the cardiovascular system. So we will first start in the region above the clavicle to be sure that the apex is percussed. And we will do the same on the other side. And we will continue with each intercostal space in the midline, all the way down to the 6th space. The last space can be done a little bit more laterally to ensure that the bases are also percussed. And for this whole process, what we are observing for is resonance, which is what is expected over the lung tissue. Of course, the liver and the heart are two areas that are expected to give a dull sound when come into contact with. That concludes percussion. We will then proceed to auscultation. Auscultation is done with the stethoscope, and ideally we start with the diaphragm of the stethoscope. As usual, we will place the stethoscope into our ears, facing anteriorly forward. Ensure that the stethoscope has the correct membrane by tapping lightly on the surface. And then with the diaphragm of the stethoscope and with the clothing appropriately removed from the chest, we will ask the patient to take breath sounds normally through slightly parted lips. And we will start just as before in the apical region on both sides and proceed comparatively downwards, above, in between, and below the pectoral region. We shall be observing for vesicular breathing. This should sound like a soft, low-pitched sound which is heard all over the peripheral lung fields. There should be a long inspiratory phase, a short expiratory phase, and no pause in between them. Other sounds that we can hear are like bronchial breath sounds, which are heard over an area of consolidation. That's usually characterized by a long inspiratory phase, long expiratory phase with short phase in between, or bronchovesicular sounds, which are heard over the bronchi and are considered normal there. Both inspiratory and expiratory phases are long, but there is no pause in between them. And of course, there are a few abnormal sounds that can be associated for, such as crackles. These are discontinuous, intermittent, non-musical brief sounds in respiratory and cardiac disease. Wheezing, which are continuous musical sounds heard in respiratory disease. Bronchi, which are similar to wheezing but are low-pitched. And pleural rub, which we listen for grating sounds during inspiration and expiration. There are a few additional tests done with the art of auscultation. First, we start with the vocal resonance. We ask the patient to say 99, and we shall be listening for low-pitched sounds in the different lobes on both sides of the lungs.
99, 99,
Below the clavicle.
99, 99, 99, 99, 99, 99,
Abnormal
99,
over an area of
99.
consolidation. 99 is usually sounded very loud and clear over those areas because consolidation actually increases the way that these sounds travel. The next test is egophony. in which we ask the patient to say E and listen for a muffled E sound throughout, starting in the same pattern as previously demonstrated. An abnormal for this test will be over an area of consolidation. The E will sound like an A. And finally, we do the whisper in petrology. We ask the patient to whisper 99 or 1, 2, 3, and we listen for a faint and indistinct sounds. An abnormal result would be that over an area of consolidation, the 99 is going to be heard very loud and clear. Again, because of the increased transfer of the sounds via the solid. This concludes the examination of the anterior chest. We will then proceed with the posterior chest examination, in which case the patient is asked to be seated with the back exposed. Inspection will continue as before. In this case, the special areas that will be observed for will be the vertebral column, which should be normal with its normal curvatures. The size, shape, symmetry, and scars and swelling as before. We will also be looking at the scapula, the respiratory movements, asking the patient to breathe in and out. The position of the ribs, intercostal muscles, and the inferior angle of the scapula, which is usually at the level of the 7th rib or interspace. We will then proceed with the skill of palpation. Again, we will palpate as before for tenderness. Then we will again palpate for tactile fermenters by asking the patient to say 99. In this position, we will be placing our hands in the following pattern. In the posterior chest, the pattern will be as follows. We will first start in the apical region, which is above the scapula.
99. 99.
We will then start in between the scapula.
99. 99.
Then below the scapula.
99. 99.
And laterally around 6 to 7 intercostals.
99.
We will then also find the level of the diaphragm, which is the level where vibrations will disappear, using also the ulnar border of the hand. So we ask the patient to stay at 99 and we find where the level disappears.
99. 99. 99. 99.
And the same will be done on the other side.
99. 99. 99.
We will then proceed with the chest excursion, which will be done as before, except that the landmarks for this will be the scapula. So we will first start above the scapula with the same procedure of hand placement. We place the hands in the same position. Pinch, sweep the thumbs outward and pinch a fold of skin. Then the patient is asked to take a deep breath in and out. Again, observing for bilateral movement of the fold of skin and of the hands. It is then repeated between the scapula and below the scapula. And this concludes palpation. We'll then proceed with percussion. For percussion, again here we will be checking for resonance, and we shall be using the same pattern as before, except in the posterior chest we are supposed to skirt around the scapula, and we usually ask the patient to basically abduct the scapula by hugging themselves. We start in the area of the apex, percuss, and then comparatively same level the opposite side. Then next intercostal space. And this was repeated all the way down to the 6th intercostal space. We will then proceed with the test of diaphragmatic excursion. This is a test that is done to find out the distance between the movement of the diaphragm that happens between full inspiration and full expiration. The procedure is as follows. First, the patient is asked to breathe normally for a few cycles. This is to oxygenate the lungs. We then ask him to take a deep breath in and a deep breath out and hold it, at which point we will start percussing at the level of the inferior angle of the scapula towards the costal margin midline. We're going to be percussing from resonant until the change is made to dull. A line is marked. We will then repeat the procedure, asking the patient to breathe normally, then take a deep breath in and hold it and repeat the percussion. Again, looking for a change from resonant to dull. The distance between these two lines is then usually measured, and typically 4 to 6 centimeters is what is expected. The same is then repeated on the opposite side. The final skill tested here will be that of auscultation, in which case we will ask the patient to take normal breaths in and out, and as before, with the stethoscope in place, we will be auscultating the regions of the posterior chest for breath sounds. We shall start again in the apical region. The patient will breathe in and out comparatively with the diaphragm, and we descend to the region in between the scapulae. Below the scapula. And then lateral to the base of the lungs. Again, we shall be auscultated for the same abnormal sounds as before, which are crackles, wheezing, rhonchi, and pleural rub. We will then do the same 3 tests that we already performed in the anterior chest walls. First, we will check for vocal resonance.
Say 99.
Asking the patient to say 99.
99.
The pattern followed will be the same throughout.
99. 99. 99. 99. 99. 99. 99.
The test of egophony. Ask the patient to say E, extended.
E. E.
Again, looking for a change in the note to one of A. And then we will proceed with the whispered pectoraloquy. Patient will whisper 1, 2, 3. Here again, we will be listening for an increase in the transfer of this sound, so where it will be audible over areas of consolidation. The following is a list of some normal and pathological breath sounds. With this, we conclude the examination of the respiratory system.